I am with Dr. Matthew Corriere. He is a Frankel Professor of Cardiovascular Surgery over at the University of Michigan. He's also a vascular surgeon. He does both interventions as well as invasive procedures such as bypass and amputation, but his whole goal is limb salvage. So he exhausts all efforts to ensure that you continue walking with both legs. Doctor, welcome. Thank you so much for joining us and for all you do to save life and limb.
Thank you for having me.
So one of the key areas of research that you're working on, which I'm very fascinated in, is shared decision making. Would you talk about what prompted your interest in shared decision making, and what so far have you learned?
Thanks for that question. You know, my interest in this has primarily arisen from stories that patients tell when I see them. And, you know, there's a real span of mismatch between goals and treatment experiences among patients. And I think the two extremes where shared decision making might help is some patients feel like they're undertreated, meaning that they aren't diagnosed. They have trouble getting diagnosed and they have to go through a lot of barriers to getting treated. And they feel like their symptoms and their concerns are being dismissed or ignored. And at the other end of the spectrum are patients who maybe get too much treatment. They maybe, you know, depending on the doctor that they saw for their problem, they had a very aggressive approach and don't understand what happened to them and kind of got swept down the line toward a procedure because they never stopped to have a discussion about why are we doing this and what can I expect in terms of the outcomes. And I think shared decision making is the spot where those are the two areas, under treatment and over treatment, where it has the most potential to impact treatment choices. And I think it's something that in the current way we see patients in clinic, it's very fast paced and there's a lot of time constraints on the doctor. So it also occurred to me that we need tools where patients can identify what's important to themselves and get comfortable putting that in front of the doctor and trying to engage them to get on the same page in terms of, you know, what the goals are and what a successful outcome looks like.
So who's involved with this shared decision making? Is it when it comes to, when you're talking about shared decision making, you're talking about all therapies for treatment, right? You're talking about medical therapy, you're talking about surgical therapy. And does this involve, especially at the treatment level, does that include the primary care physician in that shared decision-making process? Or is that at that point purely between the vascular surgeon or the interventional radiologist or cardiologist and that particular patient? At what point is whom involved?
You know, my focus has been clarifying the patient's values and quantifying them in a way so any doctor could look at them and apply it to the circumstances at hand. And, you know, in the world of shared decision-making research, it's very easy to do shared decision-making for a treatment scenario where you're going to do this treatment or that treatment. It's kind of a fork in the road and you do one thing or the other. An example I use is like a vaccination. Am I going to get it or not? That's really the two options. PAD is so complicated because you can do medical therapy, you can do exercise therapy, you can do angioplasty procedures, you can do bypasses, and in some cases you can just put the patient on aspirin and watch them. And to make matters even more complicated, you can invoke several of those at one time. And so rather than trying to collect information from the patient and spit out, here's the treatment you need, it's more about here's what's important to you based on your responses, and here's the kind of things you maybe should ask about when you see your doctor, whether it's your primary care physician or a specialist like me.
And when it comes to this shared decision making, one of my biggest issues when I talk to friends who have peripheral artery disease and they're talking to their doctor about treatment options is that their doctor tells them their way is the best way, their way is the only way, and then they come to us to find out that, oh my goodness, the doctor down the street has a completely different option. And so I think that should also be considered, that while you do have shared decision making with your doctor, and you should, and it should be a joint thing, it doesn't have to be that doctor in particular. It could be you and that doctor, but then you and another doctor, and ultimately being able to weigh those options and determining for yourself then what is best for you.
Yeah, and I don't think it's ever a bad idea to get a second opinion. And I think the circumstances where you really ought to think about a second opinion in particular is when you don't hear about any options and you have, here's what we're going to do.
Yes.
And I think that's a warning sign that the patient at a minimum ought to feel comfortable saying, are there other options that we could consider or we should know about? And when I started doing this research, one of my collaborators, who's a biostatistician, actually said to me, he said, my mother is 75 and you're an expert and she's coming to you for what do we do? She is not interested in trying to help you decide. That's your job. And to push back against that, we actually did a survey on our clinic patients. And it turned out that, over 90% of them wanted to hear about all the options I'm thinking about and not have me just tell them about what I want to do. And they don't find that information overwhelming. And so, even within healthcare, we have to break down this notion that, we need to have this paternalistic, I'm going to tell you what we're doing kind of attitude. And there's sometimes doctors, for the doctor, there's an element of time to that because I have to be able to dedicate the time to get that information and consider it. Mm-hmm. There can also be an element of control. We have to get a little more comfortable treating our patient like they're our partner in what we're going to plan to do, and less like, they're the recipient of my choice all the time. And, that's what, when I got hired in my current job, I was transferring this may be a little bit off track. I met with somebody to set up my retirement account, and I had to fill out a survey. We talked about my risk tolerance and my time horizon and all these things. When you think about the fact that that's embedded into that kind of experience, but we don't always do a good job with getting that information, and we're going to go do something invasive to a patient that might determine whether they live or die or whether they keep their leg or not, we're really behind in kind of doing a more customer-friendly approach to the process.
I think that's such an important point, because we had a friend with Pad who I recently drove 10 hours to get him to someone who would save his leg potentially from amputation. I had gotten in multiple opinions. Every single one of the opinions was, you need an endarterectomy of the common femoral artery, the CFA, first, and then we can proceed with potentially tackling the CTO or the chronic total occlusion and the SFA. But we got to get that CFA open, and we need something that's durable and long-term, and still the gold standard is really an endarterectomy. You know that. But for him at 65 years old, he was like, there's COVID, it's invasive, I have all of these other comorbidities, I'm scared, I don't want to be in the hospital, this is not right for me. And we had to take a step back and go, okay, well, that intervention is going to be a long one for a nearly 100% occlusion in the CFA. And two, well, is there an interventionist that's willing to take that risk and do it? And we were able to find one. But I think that goes to your point that, it has to come back. You can recommend, and multiple doctors can recommend one thing, but if a patient is not going to be receptive to it, that procedure is not going to go well, even if it does go well, right? Because
absolutely. And we need to see that patient as a person and not a 90% occlusion of the common femoral artery. So that other element you're describing, that lesion in the common femoral artery is in a person who's got all these social contexts and expectations in their life. And if we don't factor that into what we're going to do, we're missing an opportunity to establish mutual goals and go from there.
So can we talk a little bit more? I know you have a slide deck as well to show. You were mentioning the survey that you did, and one of the numbers that you had mentioned that did stand out to me was the fact that 70% of patients said, hey, we're not overwhelmed by the information that you share with us. I do want to hear all the options. I'm still going to go with you, even though I know all my options, because I trust you. And there's so much to be said about that. That actually strengthens the trust, where you as a doctor, you say, hey, I can do this. This is what I'm good at. I'm going to do a good job and you're going to have a great outcome. But there are other options available depending on your goals as a patient. You may not want to cut all the way down your leg, but I'm good at it. I'm going to get you walking. You're going to be walking for a long time. But if you don't want that big cut down your leg, well, maybe I'm not the right one for you. And here's another option. But that patient may say, you know what, maybe that cut all the way down the leg is worth it for me to have you because I like you and I trust you as a doctor, because you are open with me. You are transparent.
No, I think that's reasonable. And a lot of times, what I love about my job and my training is that, I don't have to send the patient to someone else. We can individualize within. I think knowing your doctor's scope of practice, you never want to push your doctor to do something that they're not comfortable with or experienced with. By the same token, your doctor may be able to offer more than one option, and there's more than one way to skin a cat, as they say. And so getting that out there and initiating that conversation is important for sure. And you don't know till you ask. And it's remarkable to me how often, though, some patients either aren't comfortable bringing up or asking a question, or they don't even get a chance to.
Yep, it's true. Do you want to bring up your screen?
Sure, I can show a few slides. Can you see my screen?
Yes.
So this is that survey we mentioned, and we asked patients about their sources of information. What were their roles in decision making, and did they think their treatments were successful? And the result of that was that 90% of people want to talk about all the treatment options with their doctor, not just the one I pick as the best, but they wanted to know what else did I think was an alternative that was reasonable, or if there's an alternative that was not reasonable, why is that? Over 90% wanted to choose the treatment together with their doctor. So a big misconception a lot of doctors and patients may have is that they're delegating the choice completely to the physician and they're not supposed to be partnering in it. And 75% said they weren't confused. They did not feel confused or overwhelmed by too much information. And that can be a concern on the doctor's side. But only a little more than half of the patients actually said that they recalled discussing any kind of choice, which to me says there's a big opportunity to do better at engaging them. And looking at this was a question item. Did you think your first treatment was successful, or did you have a successful treatment, but it wasn't the first one I tried, or none of my treatments were successful? And for the PAD respondents, this is terrible, and we ought to be able to do better than this. It was more common for them to say some treatment was successful, but not the first one, or none of them were, than it was to say my first one was successful. And some of this may be that the doctors chose the wrong treatment. It may also be that the patients and the doctors weren't on the same page in terms of, what are we trying to accomplish here?
And what's interesting is that I find that more patients who are stuck on medical therapy and walking therapy are less satisfied than those who have surgical therapy. Because I think as a society, we're trained for a magic pill. Like in this case, it's not just a magic pill per se, meaning statins and blood thinners and beta blockers and such, but the magic pill being the surgical procedure, that they feel as though you got to cut me open, you got to do something in order for me to feel as though something's being done.
Absolutely. And, if I can screen share again for a second, the way we try to get at that information is we use kind of marketing research approaches. So, we're time limited. I have 15 minutes and we don't have a great way to bring patients into the process. And patients sometimes actually have trouble answering what's important to you about your PAD treatment. They may not have a conceived answer. And we apply this product development philosophy where we treat the treatment choice like it's a shopping trip, and we treat the patient as a consumer, and we show them a bunch of different treatments that are kind of shown as different competing products. Instead of asking them, what do you want? We let them shop and look at what they pick. And this is what Amazon and others do. If you've ever been on, Amazon can show me products that I might have never heard of, but I want to buy because they watch what I shop for. iTunes does this. iTunes can show me music I've never heard that they know I like. And I actually like that, but I don't understand. So we use an iPad tool that lets the patient enter in some demographic and other information. And then we show them attributes, treatment attributes. So this is a choice card from our survey that we use to understand. This is showing 2 different theoretical treatments to the patient. And we literally just say, if these were the only treatment choices you had, which one do you like better? You can see this top row. The first row here is describing what is the treatment. So this is describing an endovascular procedure, an angioplasty or something like that. And over here is a medication. This describes what are the odds of the treatment being technically successful, because sometimes we go attempt something and we can't cross the lesion, or sometimes we send a patient to exercise therapy and they literally can't do it. Mm-hmm. This describes their symptom response, durability, and how risky it is, because some of the procedures we talk about have a risk to the treatment. And this is how we show the patients their own preferences. We show them like a graph that shows the percentage of overall importance. And to skip ahead, this is 110 different patients, and each one of these vertical bars shows the patient's preferences. So what stands out here, this is a little confusing, but patients are really different, and they're really not, one patient is not just like the next. And let's skip ahead a little more. We have these values phenotypes, and what you were mentioning earlier, Kim, there is a group of patients, and in this study, it was a small group among those with claudication or chronic limb-threatening ischemia, that they're really focused on one treatment type, that they really either want one treatment or they want to avoid one treatment. So that's interesting. And there are others that really prioritize durability of their treatment as most important. And there are others that really prioritize technical success. And patients have different levels of risk tolerance too. And so if you put this information out there in front of the patient in a way where it's hard to ignore, and this is just 5 patients pulled out of that study, you can see this patient really, durability is important and they're risk tolerant. This patient's the opposite. They're really worried about risk and don't want to have an invasive procedure. And getting this information in front of not just the patient, but the doctor can really help them kind of become self-aware of what they're trying to accomplish. And it makes it harder to ignore, I hope, when we can show it this way.
It just goes to show, in terms of all of this research, how has it actually changed how you are practicing with your own patients? Has it changed the types of questions that you've asked them that maybe other doctors and innovators, researchers can all learn from?
It has, and I think I like to start with, why are you here today? And, I think there's kind of 2 different extremes of this. There are some patients that are walking in the door and they know I do procedures and they really, really, really don't want to have a procedure. And they somehow feel nervous about saying that to me. And it's remarkable when we go through this process with them and I say, boy, it really looks like, you don't want to bite off any risk that's unnecessary. They almost are relieved because they feel like I'm going to tell them we're going to do something to you and they can't say no to it. Mm-hmm. On the other side, there's some patients that have, been trying to get to someone that will listen to what they care about and are shocked that I want to know this information. And I've done all kinds of research in my career, but this work is unique in that the patients say, thank you for doing this. And they say, that graph I showed you where we were showing the different bars, we got all nervous about how do we show that to the patient in an understandable way. And what we came to realize that doing that process, we almost didn't need to. They become self-aware. And the other really remarkable thing I've seen is a patient sitting there with their spouse. They come to an understanding that they and their spouse, or they and their daughter or son, had a different idea of why they were there that day. And it's an opportunity for everybody to just get on the same page in terms of what are we going to try to accomplish here. And when we approach the decision about whether we're going to put you on a pill or a walking program or do a procedure, there's less uncertainty for everybody. And it makes me feel better when we are going to do a procedure that the patient's informed and it's what the patient wants. And we both think there's a reasonable chance that they're going to have a chance to feel like this was successful. And on the back end of it, say, this was a good idea.
And that's why, especially when it comes to peripheral artery disease, there are a lot of people and even insurance that say, you need to do 3 months of medical therapy and walking before we can even treat you. But you have a lot of patients that don't walk in the first place. They won't walk until they're not in pain. They realize, hey, I have to walk, but I'm not going to push through the pain. And unless you get rid of some of the pain and restore at least a little bit of blood flow, there's no way I'm going to even walk. And I'll be back here in 3 months and you're going to have to do a procedure anyway, because I'm going to stub my toe and it's going to turn gangrenous. And so when I have certain physicians that are completely conservative in treatment that will not do a procedure at all, and they're like, walk, 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 there are a lot of people that literally won't walk, 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 and you got to do something to get them so there is some sort of, you know, level of less pain so that they will actually start walking. But then you have vice versa, that if there isn't any point in doing a procedure if they're not going to walk at all once you do it. So you do have to take it individually, and that's why I really like your research. And I think the whole takeaway here is in shared decision making is getting to know the patients, understanding their goals, and not putting patients into boxes. Right?
Absolutely, and you know, the PAD is almost never there in a vacuum either. So if I'm just treating that patient like they're a blockage in this artery, but they've also got like really severe lung disease or arthritis, we need to understand how does that affect their potential to improve if I have a successful revascularization procedure. And you know, we need to find a way to take the time to think about that. And I would also say that point you made about the referral for supervised exercise, you know, it's remarkable. There's a little bit of a power dynamic when people come to see their doctor. And I think a lot of times when we as providers are recommending exercise therapy, the patient knows that they can't do it or they're not going to do it. Mm-hmm. But instead of saying that to me, because it's a little harder to, they have this sense that they're going to like be rejecting my recommendation or something. Instead of saying that to me, they either leave and get aggravated waiting 3 months to come back, or they just go see someone else, and that wastes their time. And we ought to do a little better of a job of matching the patient and what they want and what they can do to what we offer.
I think that's beautifully said. So based on all the research that you've done, what is that ultimate, how can people apply this when it comes to innovation, whether it's researchers, people who develop products in the vascular realm, and overall, I think you've painted a great picture in terms of what doctors can do, but anything else that other stakeholders can do to help in this shared decision-making process to make it more effective for PAD patients?
I think one growing area of interest that we're working on with a project I'm participating in with the FDA is this notion of patient-reported outcomes, meaning that beyond us choosing the treatment, we also let the patient in a very structured way be part of the judge of whether the treatment worked or not. So, you know, in the medical research field, we might do some tests on the patient when they come back and look at the pressure in their toe or measure how far they can walk. And I say, based on that information, whether or not the treatment was successful. With a patient-reported outcome, we actually get the patient to get more engaged with, did I actually make your life better in some way? You know, if your goal was to be able to cut your grass with your push lawnmower as a result of this treatment, I might have made your leg pressures go up and satisfied all these things that in medical journals we talk about as successful. But we need to get more comfortable with the patient saying whether it was successful or not based on what their life looked like and what they wish it could look like if their PAD wasn't limiting them.
But as these doctors have these conversations with the patients, are you finding that those conversations are productive, or ways in which they could become more productive? I know that you have some information and have studied how many times patients are interrupted and doctors are interrupted in in these 15-minute conversations that are making the shared decision-making process really tough.
Yeah, no, absolutely. There's tons of room for improvement is the good news. And this is from a study we did where we took an audio recording during a visit. So the patient and the doctor in the room together, and we just recorded what was said, and we went back and looked at how much the different parties spoke and how much were they interrupted. And you can see I was actually pleased with this. There was a pretty even split between how much the clinician and the patient talked. Family members weren't present all the time, but they accounted for about 11% of the conversation. But this was the number for the interruptions. And I'm not talking about a verbal pause. I'm talking about a patient being cut off a mean of 38 times during their visit. So that's a lot, right? And
that is a lot.
You wonder what could have been gained by letting them finish what they were saying instead of interrupting them. And when we looked at how much they talked about shared decision making, about 18% of the conversation was related to shared decision making, but most of it was describing options, and very little of it was asking the patient, what do you want, justifying that it's a shared decision between both parties. So I think that kind of shows that we could improve in terms of listening better. And when we are doing our shared decision making, I need to be sure that in addition to me describing the options, I let the patient help me pick and tell me what they want. Those are the two big takeaways from that.
Yeah, I know that when I'm in with my dad and we're talking to the doctor, it just raised the awareness here for me. I talk a lot and I interrupt my poor dad so much, and he wants to convey how he's feeling, but I always find that he ends up talking about so many other things that I know that the doctor doesn't need to hear. But sometimes you do need to let the patient get what's on their mind and off their chest.
No, that's true. And I don't know that that's totally a bad thing either. And an extension of this research we're working on now is a patient that shows up with a family member with them in clinic instead of by themselves. That's probably also an indicator of a lot of social support outside the hospital. And so you being there and participating in the conversation probably indicates there's a lot of spin-off benefits, because that patient has at least one person that cares enough about them to go along that day and is willing to spend the time. And that might have a lot of translations into health risk behaviors, into access to social support and things like that. And in our focus groups, we had patients talking a lot about that as one of those life elements of PAD. A lot of these patients feel very socially isolated. I had a focus group where a patient was saying that she goes to her son's football game and goes to graduation, and she sits in the car and doesn't go in because she can't make the walk in and out. And that's a great way to frame a goal of treatment in a way that would make a provider say, maybe we need to get more aggressive. And when you don't frame it that way or give the patient the chance to tell that story, we might overlook how much their symptoms are bothering them and be dismissive when we ought not to.
I think that's so important. And so if you were going to have, a few key takeaways from your research and where you think this needs to go next, how would you frame it?
I think we need to do a better job before the patient comes to the clinic visit, getting them in touch with thinking through what they're trying to accomplish through treatment. What are the benefits they hope to achieve through seeing me, and also what are the harms they want to avoid through seeing me. And then the tool like this, my hope, I think it's a better way to distribute this information is to get it in the hands of the patient so that they're aware of it. And then if they encounter a doctor who either doesn't want to listen to it or ignores the information, they at least have an awareness that that opportunity has been missed, and they can go seek another opinion if they want to. And I also think, beyond that, embedding these patient-reported outcomes into drug trials and device trials may help us frame the results of the scientific research from a more patient-centered perspective, where we're not suggesting benefits that patients don't think are significant or relevant to their life, is my hope.
Thank you so much, Dr. Matthew Corriere. He is a Frankel Professor of Cardiovascular Surgery with the University of Michigan, also a vascular surgeon. We really appreciate your time.
Thank you for having me.